Thank you very much, Mr. Chairman, for the introduction, and good morning to everybody, for those who are awake. So, volume replacement in sepsis resuscitation, what to give in how much time and when to stop. I think that an easy way to start to discuss this topic could be to start from the last edition of the Surviving Sepsis campaign, just published in January of 2017, in which the investigators clearly state what to do in the initial resuscitation phase. So they recommend to give at least 30 ml per kilogram of crystalloids, and they strongly recommend to use frequent reassessment of hemodynamic status, including cardiac function monitoring and including dynamic over static variables. And they recommend to achieve two different hemodynamic targets, mean arterial pressure of 65 millimeters of mercury and the normalization of lactate. So at the end, as a brief summary, we need to give some crystalloids, at least 30 ml per kilogram within 3 hours, of course, in addition with vasopressors. We need to apply some hemodynamic monitoring in order to achieve a hemodynamic stability. So I may even conclude my topic and my talk just giving you some very simple answer to these questions. What to give? Well, some IV fluids. And how much and in how much time, which I think are two correlated questions. Well, as much as needed and as fast as tolerated by the patients. And when to stop, which is the crucial question. Well, the sooner the better, I guess, as soon as possible. But I think that this topic is quite a little more complicated because there is no clear recommendation or physiological reasoning regarding the possible primacy of fluids over vasopressors. And we need also to spend a little bit more time on the possible toxic effect of fluids, especially when we are dealing with fluid overload. So what I would like to do in the next 50 minutes or so is, first of all, to give you a brief summary of the recommendations of the Surviving Sepsis campaign guidelines regarding the type of fluids and also regarding the way in which we need to administer the fluids to our patients. And in the end, I will present to you some preliminary data in order to give you a sort of reasoning about the biophysiological mechanisms possibly underlying the hemodynamic instability we see in our septic patients. So how about the type of fluids? Well, the Surviving Sepsis campaign guidelines clearly state that we need to go for crystalloids as a fluid of choice. And there's no clear recommendation regarding the use of balanced crystalloid solution over the use of normal saline, because we will see we don't have enough evidence supporting the use of one type over the other. We may consider the addition of albumin to crystalloids in specific clinical characteristics in patients, for instance, with septic shock, and when the requirement of fluids is large enough, although this is a weak recommendation with a low quality of evidence, as you can see here. And there is a strong recommendation against the use of hydroxylated starches, while there is a suggestion on the use of crystalloids over gelatins. So, as a summary, we need to use any type of crystalloids. We may consider the addition of albumin if needed, especially when there is a large requirement of fluids, and we cannot use synthetic colloids, no hydroxylated starches and no gelatins. So I would like to add a few comments on the primacy of crystalloids over the use of colloids, because I think that we need to keep in mind two different considerations. The first one is that this superiority of crystalloids over the use of colloids is based on, first of all, the limited evidence on the superiority, on the physiological and clinical superiority of one type over the other one. We have tried for many times to demonstrate that colloids are better than crystalloids, but we don't have any evidence supporting this. But in contrast, we have gained a lot of evidence suggesting that at least one type of synthetic colloids may have and actually has toxic effects. This is a brief summary of all the large randomized controlled trials comparing crystalloids and a specific type of synthetic colloids. And all the trials demonstrated that there is no difference or an harmful effect. The second consideration is that what we have learned from Handbook of General Medicine regarding the distribution volume of colloids over the use of crystalloids is actually wrong. We have learned that usually the ratio between colloids and crystalloids is 1 to 4, 1 to 3. But look at this table. This is a summary of all the randomized control trial performed in critically ill patients comparing colloids and crystalloids. And especially in patients with sepsis, the ratio between the use of colloids and crystalloids to achieve the same hemodynamic targets, hemodynamic stability, is 1 to 1. 1 to 1.2, 1 to 1. So it's the same. Basically, we need to give the same amount of fluids, both as crystalloids or colloids, to achieve hemodynamic stability. And this has something to do with probably with the increased permeability of the endothelial layer and with the disruption of endothelial glycocalyx, which is, now we know that, is clearly characterizing patients with sepsis. A couple of few words on two specific issues regarding the type of fluids. First of all, the use of buffered and balanced crystalloid solution. We know that there are some experimental evidence suggesting that the use of hyperchloremic crystalloid solutions may have harmful effect on the kidney function. But we don't have enough evidence to support the use of these solutions over the use of normal saline. This is the only prospective randomized control trial so far conducted, in which a type of balanced solution, plasmalite, was compared to normal saline, and as you can see here, there's no difference in outcome. This trial has, I think, some limitations because there is a very low severity level of the patients enrolled, and all the patients have been exposed to a very low amount of fluids. So I think that the question regarding the possible beneficial effects of balanced solution over saline, especially in high-risk patients, is still open. And this is actually why there is an ongoing trial performed and designed by our Australian friends that planned to enroll 8,800 critically ill patients randomized to receive either plasmalite or normal saline, although I kind of doubt that at the end of this trial, enrolling a very heterogeneous population, we will have a very good answer. Regarding gelatin, it's kind of strange because gelatin is on the market for about 60 years, 70 years, but we don't have enough evidence supporting its safety and actually its efficacy. And this is another reason why there is another ongoing trial performed by our German friends that plan to enroll about 600 critically ill patients in the face of early sepsis and septic shock to receive either gelatin or crystalloid solutions. So we will see whether gelatin will have some beneficial effects over the use of crystalloids. So how about how much and how much time and when to stop? First of all, how much? Well, the Surviving Sepsis Campaign guidelines clearly state that we need to start from at least 30 ml per kilograms in 3 hours. And there is an explicit explanation on why there is a fixed volume clearly stated in the guidelines. The reason is that a fixed volume enables clinicians to initiate resuscitation while obtaining information on hemodynamics and patient status. But it's kind of strange to see that this value basically came out of the blue from the previous edition of the Surviving Sepsis Campaign, 30 ml per kilograms in the 2012 edition, while before that, in the 2004-2008, there was just an indication of how to perform a fluid challenge with half a liter, 1 liter in 30 minutes as a starting point. But it's true enough that when we look what we are doing in our clinical practice, this is a study just published on intensive care medicine, about 50% of our patients are receiving probably a lower amount of dosages of fluids as compared to what is recommended in the guidelines, because this is the 24 hours fluid balance over the first day of treatment, and basically 50% of patients are receiving less than 4 liters, so probably below this level. And in the recommendation, we don't know anything about afterwards. We just know that we need to monitor the response and to achieve targets, but how to do that? It's kind of difficult to answer to these questions. In how much time? There is a clear recommendation of using fluid challenge in order to infuse fluids in our patient with a frequent reassessment. And this is based on 2 reasons. First of all, we need to give fluids only to patients that are response positively from the fluid administration. And the second reason is that we need to avoid fluid overload. This is another very nice study, observational trial, the Fenice study, that described what we are doing in terms of fluid challenge in our patients. And as you can see, we usually start from half a liter in 30 minutes. As a main indication, hypotension. But it's very, very striking that after the first fluid challenge, we are still giving fluids, not taking into account the response of the first fluid challenge. This is the percentage of patients receiving fluids after the first fluid challenge, after we have obtained a positive response, an uncertain response, or a negative response. The same percentages. So we usually do not apply any reassessment of the hemodynamic response. And when to stop? Well, this is a very difficult question, and for which we have unclear answers. This is another important study that I showed you before, in which basically there was a huge increase in mortality for any extra liter after 5 liters of fluid administration during the first 24 hours, suggesting that fluid overload is harmful. Also, when we adjust this increased risk for the baseline risk of death of these patients. So probably the answer is as soon as possible, but it's very difficult to understand how we may understand when it's possible to stop fluids. Also because I think that when we are dealing with the hemodynamic instability, in a very simplistic way, we are dealing with two different phenomena. From one hand, we have an increased permeability, and since we don't have any drug to heal the increased permeability, we need to give fluids. On the other hand, we have vasodilation, and for that, we need to give vasopressor. Of course, many times these two phenomena are overlapped, but from a physiological point of view, of two different phenomena. And the real problem is that the clinical phenotype we are seeing from our patients many times does not reflect the biophysiological phenotype which underline the hemodynamic stability we are seeing in our patients. So we thought to describe these two phenomena by using two different biomarkers. The first one was Syndecan-1, which is an endothelial disruption marker of injury of the endothelial glycocalyx. So in some way, it gives us an estimate of the increased permeability. And the other biomarker was bioadrenomedulin, which is a novel biomarker, which is thought to be responsible for vasodilation in septic shock patients. And we thought that measuring in the same patients these two biomarkers, combining the information obtained from these two biomarkers, could predict the correct hemodynamic support therapy to be applied in our patients. So we measured these two biomarkers in about 500 patients with septic shock from our Albios biobank, and we divide the entire study population into different groups according to the median value of these biomarkers. We end up to have 4 different groups. The first group with low levels of both biomarkers, so no increased permeability or less increased permeability and less vasodilation, and on the right, both high level of biomarkers, so increased permeability and higher rate of vasodilation. In the middle, we have patients with hemodynamic instability more characterized by vasodilation, and in this group, patients more characterized by an increased permeability. And look at the treatment we have applied to these patients during the first day. This is the net fluid positive balance after the first day of treatment. Of course, patients with the low levels of both biomarkers receive the lower positive fluid balance as compared to patients with higher levels of both biomarkers. But look at these patients that were probably more characterized by vasodilation. They received anyway a large amount of fluids. And probably we may speculate this excessive amount of fluids was not needed, was not necessary, and probably may have caused some harmful effect. In fact, when we look at the possible clinical consequences of this treatment applied, of course, not knowing the biomarkers underlying the hemodynamic instability, we observed in this group of patients a higher increase in the incidence of novel respiratory failure, as well as a higher increase of acute kidney injury, supporting this hypothesis. So, of course, these are very preliminary data. Just to help me to make this point, we need somehow a methodology in order to unveil the biophysiological mechanisms underlying the hemodynamic instability we have in our patients, in order to tailor more appropriately the hemodynamic support therapy to be applied in order to avoid fluid overload and to give the right treatment. Also because we know very well that fluids are harmful. This is a feasibility trial just published in Intensive Care Medicine that tested for the first time a restrictive strategy versus the standard of care. The restrictive strategy was basically applied with just fluid boluses in order to treat very severe hypoperfusion. This study was not designed to gain any information regarding the possible outcome, but it demonstrated that it's feasible. It's feasible to save and to spare some fluids in our patient, probably gaining more positive effect. So in conclusion, what can we say about fluid and volume administration in septic patients? The focus of the administration for volume replacement should be, first of all, to achieve and maintain adequate effective circulating blood volume and not just volemia during a rescue and optimization phase. We need, of course, to minimize possible complications during the stabilization phase. And we need to restore a more normal fluid balance during the escalation phase as soon as possible. Thank you very much for your attention.